Hello and welcome, everybody. This is another interview from our connectivity series in preparation for Endoscopy On Air, which takes place on June 4. And we are very grateful to our sponsors. And one of the sponsors, FujiFilm, is the topic of today's interview. And I'm traveling, or I have traveled to one of our studios, and this time in London. And here I welcome a special guest, Edward Despott from, and I love this, Royal Free Unit for Endoscopy. So I would love to have this title in Hamburg. So Edward, welcome. The topic today is a special form of upper GI endoscopy, transnasal one. And I have been working in a group called Arcade with a few guys, and one of them was Thierry Penchant. And he was always raving about what he called through the nose. And we might be guilty of not having taken him seriously enough. So I'm happy to hear that transnasal through the nose endoscopy is revisited. So Edward, I think the history goes actually back even before Thierry.
Indeed it does. And firstly, thank you, Thomas, for this extremely kind invitation. I am very honored to be part of this phenomenal creation that both you and Ale have brought from scratch, and what a timely way to do it in COVID times when everything has gone online. So thank you for the honor and the pleasure, and I am very grateful. So yes, I think transnasal endoscopy is in its prime time, especially now. Again, COVID has done a lot to kickstart things like the virtual world, but also to relook at how we can do things in an efficient way with the huge backlog that it has created. And this is my topic. So I will be talking about its particular relevance. And going back to your question about the history, transnasal is not that new. In fact, it was born at the hands of this clever guy called Reza Shakir, who works at the Medical College of Wisconsin. And he published the first case in 1994. Serendipitously, if I may, Reza was looking at the problems with the aerodigestive tract in patients who suffered stroke. And what better way to look at it if not from above? So he used to go through the nose, very similar to what our ENT colleagues do. And then he realized that when he went down into the esophagus and then he ventured forth into the stomach and into the duodenum, patients felt much more comfortable than they would doing it through the mouth. And that was how transnasal upper GI endoscopy was born. Scopes were built, longer ones, of course, than the ones that he used to use at the beginning, but these were fiber optic scopes. So there was always going to be a disadvantage in terms of optics. But as you will hear, over the years, this has improved tremendously. And even 10 years ago, as you'll see, the American Society had already given it the rubber stamp of approval. So I'll talk to you a bit about the reasons
So Edward,
why.
I think we feel comfortable in the esophagus, but when we start, it's a little bit more worrisome for a gastroenterologist. So explain us the anatomy, what Reza was confronted with, even before Thierry went through the nose.
Indeed. But before I'll talk about the anatomy, I would like to go into anatomy and physiology, if I may. So this schema shows in that's rectangle in pink is where the glossopharyngeal afferents live. And as you know, as we all know, the glossopharyngeal afferent nerve is the entry point into the gag reflex. And, if you are going to be passing with a gastroscope through the mouth, even though it is one of the commonest procedures we do in our day-to-day life, patients find this procedure to be one of the most uncomfortable. This is why we have to sedate them many a time deeply, and even with throat spray, your patients sometimes are fighting, gagging, and this reduces quality. But transnasal endoscopy uses the alternative route of the nose, so it comes nowhere close to the glossopharyngeal entry points. And so patients are much more comfortable. Of course, we also prepare the nose with an anesthetic spray, and we spray the throat just to make sure that there aren't any stray fibers. But this bypasses. It's not like oral gastroscopy using the glossopharyngeal afferents as the fulcrum, causing gagging. In this case, the tongue is free, the patient isn't gagging, they may talk to you during the procedure, and they are much more comfortable. And this is why this is such an important procedure, especially in these current times, as you will hear. And in terms of anatomy, if you learn how to navigate this short bit, and we have designed a course which is now in its 10th edition, going into the 11th one, whereby we learn as to how we navigate this. We've got ENT support, of course, to actually flag up what we may see, which may trigger off a referral. But if you navigate that bit, then it's really common territory. And anyone who knows how to do an upper GI endoscopy through the mouth can actually very rapidly learn how to do it through the nose. You need a slimmer scope, Thomas. You can't pass through the nose with a standard scope. So the scopes nowadays are about 5.9 millimeters. They have two wheels, so you can get very good control. And as you will see, Fujifilm have developed scopes with tremendous optics. And going back to history, even 10 years ago, almost 11 years ago now, the ASGE, a highly respectable society, showed that even in those times, it was equivalent. Ultra-thin scopes delivered equivalent quality in terms of the diagnostic capability. And you mentioned TRE, and here had shown that biopsies were non-inferior as well. So a lot of myths busted even 10 years ago. The Luxio system made by Fujifilm, the 700 series, has several advantages. Apart from having optics which rival or even are superior to standard scopes by other companies through the mouth, has a 2.4 millimeter channel, and this is the only transnasal scope to have this. And you'd say, why do we need a 2.4? The 2.4, as you will know from physics, improves suction, one of the downfalls which was associated with slim scopes. And suction is tremendously improved. Good optics, you can even put down instruments easily. You don't have to straighten the scope with a 2.4 millimeter channel many a time. And of course, bending ability has also been rectified in that it allows us to take biopsies even in blind spots such as the cardia, where it's usually difficult to actually target a biopsy. And this is important because if we're looking for early cancers, if we're looking for something suspicious, we need to be able to take that targeted biopsy. And the optics speaks for themselves. I mean, these are images that you wouldn't know are taken through a transnasal scope. They could have been taken through the latest high definition peroral gastroscope. They jump out of the screen and they get better and better and better as time goes on. We prefer to prepare the stomach with a pre-preparatory drink. Like the Japanese, we give a mixture of a mucolytic agent. In our case, we use carbamazepine because it's available over the counter. This is a brilliant mucolytic. It's used for cough, productive cough. A couple of squirts of simethicone, which is the bubble breaker. And of course, we prepare the nose with a local anesthetic spray consisting of phenylephrine and lidocaine. And I usually like to spray the throat as well, just in case, as I said before, we have a couple of stray afferent nerves from the glossopharyngeal. And of course, lubricant. We have to lubricate because one of the things that can make this uncomfortable is sticking on the mucosa. So we would like it to be very well lubricated. And this is me many years ago having it done. I've already had a couple of these done. And I must say that in comparison to the oral route, it's a walk in the park. It's not for everyone, Thomas, and there are relative contraindications, but I must stress the word relative because if you have a history of severe nasal trauma and your septum is deviated, that means that one of them is narrow, but the other one is wide, so you can still pass through many a time. Recurrent epistaxis, unless they suffer from Osler-Weber-Rondeau syndrome, of course, is a relative contraindication. And although it's quoted to be up to 6%, the rate of epistaxis in our hands, where we do hundreds, if not thousands, this is extremely low. It's less than 1%, really. A bleeding diathesis, of course, relative. You're not going to do it in someone with an INR of 7, of course, but it's relative. I think the main one is going to be lidocaine allergy, because if you do not anesthetize the nose properly, they're going to find it uncomfortable. So I think the only real contraindication is lidocaine allergy. Risks, very low. Epistaxis, rare, as I said. Of course, you're passing through the nose and you might cause sinusitis, but that's very rare. And sometimes bugs may creep up the lacrimal gland, extremely rarely causing dacrocystitis.
Edward, when I'm listening to you, I already feel bad to still use the through the mouth approach, but do I dare to ask about evidence, comparative evidence? So maybe you tell us a little bit about that as well.
Indeed. Thank you, Thomas. So yes, I'll summarize it with this systematic review, which was published by Chris Raghunath's group already 6 years ago now. And Chris and his colleagues looked at all the evidence in the literature at that time, and it's impressive. Over 6,500 patients, 34 studies, and almost unanimously, they showed that transnasal endoscopy was associated with superior patient satisfaction in terms of diagnostic ability, equivalent, and it is not just the nature of the scope. People would argue, oh, you're getting a comfortable procedure because you have a thin scope. No, it's the route of approach, as I said before, because you are not stimulating the gag reflex. So it's the route of insertion, the transnasal route. And we had echoed this way back in the day when I was presenting my thesis. We had done a study at St. Mark's when I was there. And it also echoed the fact that this is much more comfortable and non-inferior in terms of diagnostic yield, even for biopsies, as shown by Thierry and colleagues, and associated with no real complications or safety issues. Coming to complications, Thomas, there is evidence that this is even safer when done in patients who are at risk of cardiac stress. If a patient is uncomfortable, their cardiac stress goes up and they may suffer complications. So my good friend John Pleveris from Edinburgh and his group showed that this is superior in terms of reducing the risk in patients who are suffering from cardiac disease.
Edward, I buy it, but these are the old times, right? So tell us why this is fresh and why this should be revisited.
Indeed, Thomas, thank you for this opportunity to say why this is a renaissance of transnasal endoscopy. We are really revisiting this because COVID has made us look at things in so many different ways, and we have to think outside the box. And of course, in COVID times, everyone is tremendously terrified of aerosols. You mentioned the word aerosol and you get scared because with the risk of variants now, I know that we have vaccines and we're currently controlling it, but who knows whether there's going to be an escape strain. So aerosols are still very relevant. And I'll take you back to this model. This is a cough model that showed that this is an explosive, like a shotgun effect, as I've drawn here. And it's the whole rationale about why we use surgical masks. It cuts it at source. It saws off the shotgun. So like that, we are less prone to having aerosols in the environment. And transnasal can be done through a surgical mask with a slit. We've published something in Endoscopy a few months ago, even for through the mouth, but especially through the nose. And I see that evidence is coming out. So the Japanese showed a very elegant design study where they had lasers and showing this fluorescent dye in a model. And this is the doctor who hadn't had a patient wearing a mask during a procedure, a transnasal procedure, and here with a mask on. And you can see it speaks for itself. It's like the parachute test, Thomas. And this is a paper that is being reviewed to be published by our dear good friend, again from Nottingham at Olfo Parablanco, showing that aerosol generation in transnasal is half that generated by the oral route. So although there is still debate about upper GI endoscopy, the reality is that these things still do generate aerosols, and transnasal is a cleaner one, let alone if you combine it with a mask as the Japanese show. And this is us doing it rule-free through the mask. This is a lady who had a history of some weight loss and iron deficiency anemia. Going back to your anatomy question, Thomas, this is it. If you know how to do this, it's easy. You're back into common territory. You can see our familiar views. It also allows you to look at the vocal cords much more accurately. And then it's common territory. And you can see the views. It's incredible. The views jump out. They're so good. And you can even combine them in the FujiFilm scope with linked color imaging and BLI, blue light imaging, and you can get that contrast which is seen in other scopes. So this is the general view, some atrophy. I flick on LCI, and then in due course I find this ulcer, which I interrogate with LCI. Of course, we've biopsied this, and just in the interest of time, I'll speed this video up to show me taking biopsies of the duodenum. But let's listen to a patient. This was a patient who was really scared. This was one of those who would require general anesthetic, and her testimony speaks on its own.
I'm quite an anxious person, and having this experience of the oral endoscopy that heightened my anxieties. I thought I'd never do it again. And then I read up and Googled other ways of looking into the stomach, and transnasal came up. After reading reviews, they said it was a lot more tolerable. So I thought, well, let me try that. But I still had the anxieties of the endoscopy, which was a really bad experience for me. And actually, after having this procedure, it's made me realise that it was all kind of built up in my mind from the previous experience I had, and it was a lot more tolerable. I could actually speak, I could actually breathe, I didn't have any gagging at all, a little bit of kind of wind. So I'm actually so much happier that I went this route rather than the endoscopy, because I had all these anxieties of not being able to look into my stomach. So yeah, I would 100% going through that now. I would do it another 10 times.
Would you recommend it to patients?
100%.
That it should catch on as a sort of, way forward in the UK?
Absolutely. I mean, for me, being anxious, if I can do it, anyone can actually do that, because I was very tempted to just go back home today without eating.
So, Thomas, it speaks for itself. This is a very anxious patient. She would have bolted out of the door. So what are the advantages? You don't need to sedate patients. And in COVID times, this is particularly important because it leads to immediate recovery without the need for extensive recovery areas. So there's automatic social distancing because the patients leave the department immediately. It is less aerosol generating, especially if combined with masks, as we've seen. You need less personnel. You don't need anyone sucking the mouth because there's the patient who can swallow and they're comfortable. It's ideal for rapid turnaround, okay? It's ideal for one-stop clinics, as we've developed in Royal Free. We have a dyspepsia clinic whereby the patient comes in, referred, for example, on a 2-week wait pathway, suspected cancer. We take a very brief history, we go into the room with the patient, have a transnasal, if need be an ultrasound, and then they have a diagnosis on the same day. Rapid. And community endoscopy units, or even in the outpatient department. It's non-inferior in terms of diagnostic, including biopsies, high patient satisfaction, again, no need for sedation, which translates to safety, cardiovascular risk especially, and also cost-effective, because all these tie in to cost-effective strategies. And if you buy an ultra-thin scope, you're not going to waste it, as it were, just for transnasal. You can use it for other things, neonatal use, pediatric, help with a complex polypectomy for traction, for example. You can insert nasojejunal tubes directly, and even a peg, Thomas, because all you need is a camera sometimes when you push a peg through using, for example, the Frika Pegzact, especially in patients who have contraindications to the pull-through technique by Ponsky. So in conclusion, Thomas, I know time is at a premium. I hope I have shown you that this is better tolerated and safe, especially in COVID times. It is non-inferior in terms of its diagnostic ability, including biopsies. No sedation is required. Rapid recovery and turnaround, of course, associated with that. Less personnel, less aerosol generating, high patient satisfaction, and cost effective. And I will put in this plug because I think it is important that people know about this course. It's the only one in the world, and it's now massive. It's grown. We had about 200 delegates or more from all over the world recently, and it's held at the Royal Society of Medicine, which is also the home of our International Advanced Endoscopy Masterclass. And I hope that, as you can see in the background, we will be able to meet in person again, hopefully in September 22. Of course, I'd love to thank my team, especially my dear colleague and friend, Dr. Alberto Moreno, and I thank you.
Oh, thanks very much, Edward. That was very, very convincing. And I especially like the last photograph of people standing close to each other without masks, so that we sincerely hope that this time will come with the vaccination progress. Well, my final question is, you know, the brave northern countries, they are more prone to unsedated endoscopy. So when COVID goes away, you still have to take the southern fortress, and this starts in Germany. You know, put propofol into the patient and off you go, and there's no coughing. But we will see. So I don't want to go into this discussion now. But from your perspective, the small ones, transnasal route versus the big ones. So even if it's only in the north, but where do you think this will be in 5 years? What's your vision?
A very good question, Thomas. Of course, it's all about perception and myth busting. This is available. This is shown now to be equivalent and potentially superior to the standard oral route. So I think, and I firmly believe this, that if we myth bust, if we really appreciate how useful this can be, even in terms of health economics, patient safety and satisfaction, and combining it with the risks relating to COVID, this is going to become mainstream, in my opinion, and it will be a bit akin to the ERCP, MRCP model. We don't do diagnostic ERCP anymore, and we will be doing diagnostic upper GI endoscopy through the nose using these scopes, and reserve the oral route with propofol and all that for the therapeutics. And that is the model relating to ERCP. So I think it is here. I think this is a really fantastic renaissance. It is the time to revisit it, and COVID has been again the catalyst to bringing this to the forefront. It so very well deserves.
Great. So let's see, Edward, what happens, whether you take the southern fortress. But at this time, I thank you really very, very much for this enthusiastic and convincing lecture. And please tell all your friends to join us on June 4 in a bit more than a week from now. And we're going to show you all kinds of procedures, 12 hours from all over the world. So thank you very much, and goodbye to everybody.
Thank you so much, Thomas. Thank you.
Thank you.